Hello, everyone. Thanks for the opportunity. Great talk by Rakesh and Amir. They discussed the basics, some tips and tricks for the diagnostic. So we're going to take next step and talk about some of the complex interventions. So some disclosure, this is our experience. There are many people who do it differently. So I just want to say, we have been doing this from last 3 to 4 years. And our approach, as Amir said, is to do it fast and do it consistently. That's the goal. I have 4-year and 2-year-old. I need to go home by 5 o'clock. I have no intention of staying in hospital. So radial in the beginning is a little bit pain in the neck, right? It's a learning curve. And I said 50 to 70 cases, we have to get used to it. You have to train your staff. You have to train your fellows, your nurses to do it comfortably and consistently. So let's start. This is nothing new. Like cardiologists has been doing this for the last 20, 25 years. We're just tweaking it a little bit. So don't let anybody tell you this is something new in your world. They already have all the pathway from wrist all the way up to subclavian. All we have to do is just find a way to go up north a little bit. That's it. So in this lecture, I'm going to talk a little bit why I chose radial approach more, patient selection, our experience, and some procedural tips and tricks. So this is the case when I joined last year as attending. This is my second week of attendingship. The lab is not set up for femoral. This is radial cases. This is a nice case came in. It's symptomatic carotid artery. We want to put a stent. Fine. We went femoral. Case went beautiful. We high-fiving. 15 minutes. Great case. So 30 minutes later, the patient started to drop his pressure. It went from 100 to 80 to 60/0. He's tachypnic. He's unstable. The first thing for young trainees, after a procedure, when this happens, you have to think about retroperitoneal hematoma, or there is bleeding somewhere. The patient is on dual antiplatelet. We anticoagulated this patient with full dose heparin. So we brought this patient straight to angio, no CT scan. Thank God we have great body colleagues. They shot an angio from the other side, and you can see there's a contrast extravasation right there. They went in quickly, put a covered stent. This patient survived. But that made me think there is a better way of doing things. So why to take a chance? It may happen you once in 6 months, once in every year, or once every month. So our rationale became at that point that we have to figure out a way to do things in a better way. So we chose radial first approach, almost a year now. We'll try radial first. If it doesn't work, of course, we'll go to femoral. That's a backup option. And then you have these patients. I'm sure some of you get, middle of the night. And I was scared to do angiogram on this patient, let alone stroke. Now, I just don't care. If you fit on my table, which is 400 pounds, we will do your case. We just don't care how much you weigh. So these are some of the advantages. Other speakers have talked about it. There's less radiation in pregnant patient. You go radial. You protect with the lead shield, and you just go straight into the vessel of interest. Easy access in obese patients. Elderly patient with atherosclerotic disease, radial artery, you rarely see atherosclerosis. Full dose anticoagulation, dual antiplatelets, bovine arch, type 3 arches. Is cost effective. We just presented a poster saying every angiogram we do, we save around $400 to $500 to the hospital because its patient can be discharged in 1 to 1.5 hours. As compared to femoral, you have to do 4 hours. Or also TR bands are very cheap as compared to MINCs or AngioSeal if you're using it. It's safer, and the most important is I don't get any 2 a.m. nursing call, or my fellow do not get any of these calls for growing pain, for hematoma and bruising. None of my patient calls us. They're happy. They may have some tingling or numbness of the arm, but that's pretty much we have. And then I came across this paper. It's a paper in 2016 by lawyers, and they looked at all the literature in cardiac from 20 years, and they found 340 lawsuits for access complications. And 59 of these claims patients have died because of access complication. And 29% of this time, they're won by plaintiff. So we better get ready in the next era that if you have a complication, we need to explain them why we didn't choose a different alternative, which is proven to be a safer alternative. So what's the barrier, right? Why you want to do that? There's lack of data. We are generating data slowly. There is a technical curve. And around 50 to 70 cases, I will say, that you need to do to get comfortable. Then lack of training and awareness. And then physician, right? Like, we don't want change. We have done thousands and thousands of these cases. We are so comfortable. Why to change? So these are some of the tricks we use. So you have to set up your room, again, the same way you set up your femoral. Like, it can be different. If it's different, you're likely that you're not going to use it. Then again, start with diagnostic cases, then go on to interventional cases. You have to know your tools, and then you have to experiment a little bit. Train your staff, extremely important. You don't want a complaining fellow or complaining nurses that, why are you making it harder for us? And then your willingness to make it happen. So this is the room setup we do. If you have a merit board, you can place it. We use an extender also. And then we put a bunch of cushions across it to make it to the level of groin. And then in the end, it looks exactly like groin. It doesn't feel different that you're doing something different if you're puncturing a radial artery. And also, if you see, we prep the femoral as a backup. And we just create a hole in the drape and then put the sheath through it. The second, we got this EDUP radial board. Recently, it's an amazing board made by this New Zealand company. It has extender. So all your catheters actually rest on this nice platform. And you can do a distal radial with it. You just have to make the patient go prone versus in distal radial position. And once we prep it, it looks exactly like you're in groin. There is absolutely no different in preparation. And our techs now are so used to do it in 5 minutes. It's a stroke case, diagnostic, they don't care. They all need to hear a word radial, and they prep it. So that's my algorithm to doing. We start doing with diagnostic cases. Then you start doing some easy coiling, BTOs, tumor embo, straightforward cases. Then you go on to do some stroke cases. Then flow diversion, and in the end, I think stenting is still takes a little bit time. So you have to get around 50, 100 cases of intervention under your belt. Then you start doing carotid stenting, and then Lusoria, which we're going to talk later in the talk. So Allen's or no Allen? I mean, Rakesh was mentioning about that. We used to do religiously Allen test in every patient, and we used to not to do radial access in type C and type D. From last 1 year, we have stopped doing it because there's a big study came from cardiology again, and they looked at thousands of the patient, and they found Allen test has no benefit. So even if the patient is type D or type A, it just doesn't matter. Hands have so much more collateral, just not by just ulnar, but they have some little small collaterals. Even if the radial gets occluded, the chance of having hand ischemia is very rare. It's a case reportable evidence. So we haven't done it, at least for the last 6 to 8 months. We just don't do it anymore. And then Amir, for your case, we use ultrasound in every case. Again, cardiologists have done this study. So their time to access is very faster if you use ultrasound. Your number of attempts are less, and your artery doesn't go into spasm. So it's not just to measure the radial artery itself, but to decrease the pain to the patient and to avoid spasm. So we religiously use ultrasound. Once you get in a habit, it comes faster, like anything else. And I use double puncture technique. Some people use single puncture. It's up to you, whatever you're comfortable with. So this is what we are showing. We use ultrasound, and this for the purpose of video, we just doing without it. And you see we puncture the artery. We're withdrawing the needle slowly. We're waiting for the flash to come back. And then as soon as it comes, you're in the middle of the artery, you thread your wire. What cocktail to be used? I've asked this question. I've been asked this question a lot of times. Again, the data is all over the place. We use 2.5 and 200 of nitro. You can repeat the doses if necessary. As long as the pressure is stable, there's absolutely no harm in repeating as many times you want. So I have sometimes given 10 milligram of verapamil and 400 of nitro. So again, Rakesh has showed this video already. So the easy way to form is into the descending arch. You put the wire, the catheter goes into the descending, then you pull back the wire so that the catheter can retain its secondary shape. You kind of twist and push. That's the trick here. And then it goes nicely, your catheter is formed. If it doesn't form there, then you go over the valve. And I usually don't fight. If the catheter wants to, wire wants to go over the aortic valve, that's completely fine. The most important point is that you have to get the wire, you have to get a lot of purchase. Otherwise, the wire is going to go into the heart. So get as much purchase you can, and then just track the SIM over it, and then it forms very nicely. So this is the paper we wrote in JNIS. Again, the trick is, if your wire wants to go to right common, let it go to right common. Even if you have to catheterize the left common, that's fine. Just track it into the right common, get the wire out, and push it into the arch and form the catheter. So it just doesn't matter, you know. You can form it over the valve, over the descending, ascending, into the right common. Just don't fight with it. So we just published this review article. There's some videos. You guys are more than welcome to check it out. So what's my setup? So we always use ultrasound to measure the artery. And if the artery diameter is between 2 to 2.3 millimeter, especially in young females, they go into spasm very, very quickly. I usually put a 6-French short sheath. I do cocktail, 200 of nitro and 2.5 verapamil. I repeat it if I see an spasm. I always do a run before going into the brachial. I like to use a non-tapering catheter, Envoy, but you can use a benchmark also. That works fine. I don't exchange. We usually put a 125 long SIM2 catheter, and then I put a once you know the catheter is up into the interest area of into the vessel. Let's say in right ICA or left ICA. Then we put an Avian 058. You can put a phenom microcatheter, Synchromeyer, and you can do you want a pipeline coiling. So this is the case we did in a 15-year-old patient, very young girl. I was worried about spasm. Artery measures only 2.8 millimeter, but she was intubated. So that's the thing. If you want to try, at least in young females, make sure the patient is heavily sedated or intubated. That makes them less anxious, and the artery goes bigger in diameter. And here you can see we are forming the SIM over the aortic valve, but I did a mistake here. I pulled the wire a little bit too early, and you can see the catheter kind of started to herniate into the heart. So I realized it. I pushed the wire more. And sometimes it wants to go into descending arch, which is even better, and then you track the SIM over it. And then you have your SIM up into the right ICA. You track the Envoy into the last picture all the way up. There's a pseudoaneurysm which was growing. We put the pipeline. There is stagnation there. She has a small pseudoaneurysm 2 months later, actually. Asymptomatic, she's completely fine. What if you want to use more support? Like I like more support. So our diameter artery has come on 2.4 to 2.5 millimeter that I'm comfortable putting a large bore catheter. If it's 3 millimeter, you absolutely don't have to worry about any spasms. But usual range 2.4, 2.5 is I'm really comfortable. So artery to A by S ratio, or artery to sheath ratio, is a common sense. The cardiologists have tremendous literature on this. So you measure your artery, you measure your outer diameter of the sheath. If it's 1 or bigger than 1, you're safe. If it's smaller than 1 and significantly smaller than 1, then you're going to have a problem. The catheter may get stuck. So in the beginning, I will advise that use an artery which is at least 2.5, 2.6 millimeter. I like Infinity. It tracks well. Balt has, some people have experience with Bellas catheter, which is good. Neuron Max, our experience has not been so good. Then we prefer GI. Awake, again we said patient can be anxious. Then we either place a 6 French or a 7 French slender sheath. Then I put a cocktail through that short sheath. I repeat if I have to. Then we put in a J wire. Then we remove the sheath, and then we track O8 catheter along with the J wire bare back. Then again I'm not exchanging, and then I put a SIM2 over it and catheterize the vessel. So I think this is the video. Rakesh has shown it. I'm going to show it again. So this is our fellow getting the access. He's putting the wire. It goes smoothly. We put in a 6 French sheath. You can use a 7 French slender sheath from Terumo. I always do an angiogram to see what's lying ahead. Our J wire is going up. And you see the Infinity with its introducer. It may get stuck a little bit at the skin. You may have to nick it a little bit. Then we're forming the SIM over the aortic valve. And then we catheterize the vessel. One trick here also, sometimes the SIM will not go up easily. So what you can do is you can just track the Infinity over the wire. Don't fight the SIM to go up all the way. You can just track your guide all the way up over the wire, and it goes very nicely. And then you can track intermediate if you have to, if you're going distal into the ICA. In this case, we were fortunate that SIM went up easily. and the catheter was there. So this was the pipeline case. We deploy a pipeline, 6 months, pipeline gone. Now, do you have to use SIM every time? So that's where I want to get faster, because forming a SIM takes time. Sometimes it doesn't go to descending, sometimes it goes to ascending. So this was the patient with a dissection, it was having strokes. We did this angiogram, and we saw this is a nice angle. I don't have to use SIM. What I did was I used an angle Bernstein. And with the wire, wire went up easily into the external. We track up the envoy, and then we drop the pipeline. So for the right side, I actually don't even use SIM anymore. We just use an angle catheter. It goes nicely all the way into the right ICI. So posterior circulation stroke, it is, if you guys are, the one message we can give here is, for any posterior circulation disease, we should not be puncturing femoral artery. There is absolutely no need. The cases are so simple, just going through right radial or through left radial. So this was the case we did around 6 months ago, and even we were radial first, not for the left ward. So this lady came in with a basilar occlusion. This was left ward was dominant. It's painful to prepare left ward. You have to get the hand all the way across, all of that. So we said, fine, let's go femoral, 2 a.m. in the night. We're all exhausted. And we fight for 15-20 minutes. Every time you put the catheter up, it will fall down. As soon as you put your intermediate catheter, it just falls down. So we find, let's go radial, left radial. It was simple access. As you can see, we put the wire all the way up. This is, again, a word catheter, I believe, 125. It tracks nicely, straightens the whole system. We put our envoy all the way up. And that's our aspiration catheter there, and artery was open in less than 10 minutes. So carotid stenting, and that's where it may get trouble, just because these patients have a lot of calcification. They have a lot of athro in the arch, they have athro in the femoral artery, and a lot of loops. So this is one case we did a few months ago, and again see it's in high bifurcation. And you can see the radial artery is actually around 2.3 millimeters. So I was a little bit nervous, and we do them as moderate sedation. We don't intubate this patient. So we said, fine, let's try it. What's going to happen? If it doesn't work, I will put a TR band and I will puncture femoral artery. We put, again, our infinity with the introducer wire. You can see it took the path of right common directly. This is our infinity into the mid common artery. And as you can see in the middle picture, that right here, that as I'm trying to advance my intermediate Navian with an micro wire, it got stuck. It's not moving. Because of this, then we took out we did a small run, and we see there's a kink in there. Because these catheters, they have a lot of transition zones, and they're supposed to be flexible in the distal part. Otherwise, they're going to have a lot of dissections. So this is one thing that we have to keep in mind. Then in carotid artery, I will advise to use a short, like 80 centimeter sheath. And if you're having trouble, some resistance, think about the kink in the catheter. So this case, I removed the micro wire. It was damaged. Then I'm pulling back to straighten the system a little bit. Let's see, my catheter is down, and this was more than luck. Anything, I just pushed the Navian all the way up into the distal common. So, and then we put a balloon, put a stent. The case went fine. So even if your catheter is right in the innominate, it gives you enough support to even drop a carotid stent. You don't need a catheter all the way up. As Losoria Rakesh was saying, it can get a little bit tricky. So for the young trainees, Losoria is an aberrant artery here that instead of coming from the far left, it's the last vessel which is originating, the right subclavian. So if you're bringing your catheter, it's going to go into the descending for the most part. You may catheterize some of the left common and right common, but it's very hard to get into the internal coming from this acute angle. So we thought, why not we come from the left side? So we put our catheter here. As you can see, this is our envoy, this is our SIM2, and we just slowly, gently, twisting it, get the wire out, and see if the catheter will take the shape. And here, we're just pushing it. I'm trying to just push it into the ascending aorta, and eventually, it does form the shape. And after that, it's exactly the same process you do from the right radial as the left radial. And once it's there, so in summary, this is safer for the patient. You start with diagnostic, then advance to interventions. Size is the most important factor along with the anatomy. That's why we recommend ultrasound in every case. And then you have to be cognizant about your artery to sheath ratio. You need 50 to 100 cases to get comfortable. And then your commitment. You have to just commit that we have to do it. And then I leave you with this message. Thank you.